Assalamu alaikum, it's me Dr. Muhammad Naseem Shirzad, and today I am going to present my presentation on non-neurogenic mailers, and that will be specifically include the benign prostatic obstruction. So we will be talking much more on BPO, means the benign prostatic obstruction. But before going to discuss in detail, let's to discuss some basic definition uh, regarding the various terminology which we will be using in this whole discussion. One is the benign prostatic obstruction, which we call it is the BPO. The other is the acute urinary retention, and then the chronic urinary retention, and then a high pressure chronic retention. There's a terminology which is using much of the time, and then we will be discussing the post obstructive diuresis. So these terms and terminologies are important. Number first, let's discuss the acute urinary retention. The acute urinary retention is defined as a painful. One thing is that it is a painful. The second thing is that the bladder will be either it will be palpable or percussible, and the patient will be unable to pass any type of urine. So there are three things in acute urinary retention. It will be painful, the bladder will be palpable or percussible, and the patient will be unable to pass a single drop of urine. Now coming to the chronic urinary retention. Chronic urinary retention of the urine is different from acute, like it is non painful, means it is a painless, it is palpable or percussible, and the patient has passed some urine. So such patient may be incontinent. So the difference between acute and chronic retention, that acute is a painful, chronic is a painless or non-painful. Both are palpable or percussible. In acute retention, the patient is unable to pass even a single drop of urine, while in case of chronic urine retention, the patient may be incontinent and may have passed the urine. The other terminology is the high pressure chronic urinary retention, and it can be defined as the maintenance of a warding, means the patient will be having a warding ability and the bladder volume more than 800 ml, and the intravesical pressure is more than 30 centimeter of water, and that is accompanied by hydronephrosis, is called a high pressure chronic retention. And the treatment of this high pressure chronic urinary retention is important. And the patient in acute condition, there are two type of treatment for high pressure chronic urinary retention. One is the acute treatment and the other is the definitive treatment. The acute treatment involves the catheterization to relieve the pressure on the kidney and to allow the normalization of the renal function. And the definitive treatment include the TRP or long-term catheterization. And a patient who are unable to wide hip, there should be no trial without catheter given in these patients. They should be offered TRP or long-term catheterization. Now, if a patient want to avoid TRP or long-term catheterization, so the option of clear intermittent catheterization can be given. The second thing is the post obstructive diuresis, and we divided it into two types. Number first, the physiological post obstructive diuresis, and the second is the pathological post obstructive diuresis. And we define diuresis as more than 200 ml of urine per hour per 2 hours or more. So this is the definition of diuresis. Now, in case of physiological diuresis, like in case of chronic retention, there is no problem at all at the kidney level. The kidney is working normally, but there is some distal obstruction. So, on relieving that obstruction, we are actually the patient is going into a stage of physiological diuresis. That's why the observation of such patient is important for potassium, and the patient may be need IV fluid replacement. The other is the pathological post obstructive diuresis, and that's maybe the patient is having some problem at the collecting duct. I means if the patient collecting duct is not responding into ADH hormone, which is an antidiuretic hormone, and the function of that hormone is the water retention. It is a water retainer hormone. So if ADH is not working on the collecting duct, so you will be passing a lot of urine. This is called a pathological diuresis. Or maybe there is a patient is having problem of increasing the production of anti-nutritic hormones, or the patient is having inability to maintain medullary solute gradients due to increase in the blood flow. So in such a condition, when the patient having pathological diuresis, their GFR and creatinine level take long time as compared to pathological diuresis. So in case of pathological post-obstructive diuresis, the GFR take long time to recover as compared to the creatinine, and GFR taking more than 3 months to fully recover, but the plasma creatinine return within 14 days or 2 weeks to return into normal. And the reason behind this early return of the creatinine level in pathological post-obstructive diuresis is that creatinine is produced both by tubular function as well as glomeruli. I means about 80% of the creatinine clearance occur due to GFR, and 20% of renal tubular secretion occur from tubules. That's why it recovery is early within 14 days, but GFR taking around more than 3 months to recover into normal. The other terminology is the lower urinary tract symptom, which is a broad term, and we have divided the lower urinary tract symptom into three. Number first is the storage symptoms, the other is the widening, and the other is the post maturation symptom. So there are three main components of lower urinary tract symptom. One is the storage symptom, the other is the widening symptom, and the other is the post maturation symptom. And to remember it in an easy way, we are using the formula for that is the pun wise. Pun means frequency, urgency, nocturia. So this pun part of pun wise is actually for the storage symptom. So frequency, urgency, and nocturia, these are for the storage symptom, and the widening symptom we are using the formula for that is the wise, which include W for weak stream, I for intermittency, S for straining, and I for incomplete emptying of the bladder. So these just a good classification and mnemonic to learn this loads. Now coming into the history, the proper workup of the patient of benign prostatic obstruction. So as we know that will be taking a proper history and then examination of the patient. So in history we using multiple time of questionnaires. So far, there are various type of standardized instrument that we are using for the measurement of alerts in male patient, and that has been used for the symptomatic benign prostatic enlarged patient. And these questionnaire include the International Prostate Symptom Score, which we call as the IPSS score. The other include is the American Urological Association symptom scores. The other is the Danish prostate symptom score and the Bristol male LUTS. But currently, the IPSS questionnaire, which is derived from the AUA guideline questionnaires, it is the most commonly used instrument, and that has been shown to be a very valid, reliable, and reproducible. And the now let's discuss the IPSS scoring system. The IPSS is actually 8-item questionnaire. There are 8 questions in this IPSS score, and it consisting of 7 symptoms and 1 about the quality of the life. So there are 8 questions, 7 on the symptoms and 1 on the quality of life, and it is being divided into asymptomatic, mild symptomatic, moderately symptomatic, and severely symptomatic. So their total is from 0 to 35. 0 is asymptomatic, 1 to 7 is mild symptomatic, and 8 to 19 moderate symptomatic, and 20 to 35 is severely symptomatic. But one of the limitation of this international prostate symptom score is that it is not telling us about the incontinence of the patient. I means it's the main limitation that it lack the in the assessment of the incontinence. It's not telling us about the post maturation symptom and the whether caused by each symptom separately. And one thing which is important, that this questionnaire is for patient, that this should be filled by the patient, this should not be filled by the doctor. So it's important in exam, if they ask about the questionnaire, that questionnaire should be filled by the patient and not by the doctor. And we are giving these patients after proper questionnaire, we are advising them the frequency volume chart and the bladder diary. So, what is the difference between this frequency volume chart and bladder diary? The frequency volume chart is actually recording the volume and time of each void by the patient. And the bladder diary, it include the frequency volume chart, but it also include the additional information of fluid intake, use of pads, activity during the whole recording, or the grade of the symptom, severity, and the bladder sensation. So bladder diary is a combination of FVC plus fluid intake. Now, the parameter that we can take from this FVC and bladder diary include, we can assess the daytime volume of the patient, that can give us the information that is he passing the whole urine, how much he is passing. Then it can tell us about the nighttime volume, the voiding frequency, the total voided volume, and the fraction of urine production during the night. So it gave us a whole assessment of the intake and output of urine. So the it should be performed for at least 3 days, because if we advise it for more than 3 days, the patient can lose the compliance and he may not be compliant because it's a difficult job. And we use this as diary to assess the male LUTs with the storage symptom, and especially we are using it for to assess the nocturia. Now, after taking a proper history, the next step is the physical examination, and it is very important. But the most important area which should be particularly focused, that include the suprapubic area, the external genitalia, the perineums, and lower limb. So these four areas should be particularly focused and assessed. Suprapubic area should be assessed. Is there any swelling? Is the patient in a chronic retention? So it should be assessed. The second is the perineum. The perineum should be assessed even by putting a torch to look just behind the scrotum for any surgical procedure, for any trauma. And the patient lower limb should be assessed. Why we are assessing? Because the patient may to check for gait, the patient may be having some spinal injury, maybe in order to exclude the neurological component or the neurogenic bladder component from examination. And then we will check the external genitalia for any urethral discharge or any meatal stenosis, phimosis, penile cancer must be excluded. The other things which in examination is important is the digital rectal examination. And whenever the order is given regarding the examination of abdominal examination, and on history you assess that the patient is having LUTs, must go for digital rectal examination because it will help us in the assessment of male LUTs. So after taking proper history and physical examination, now let's discuss the various investigation for a patient of LUTs. The first investigation which we are advising in our clinics is the urinary examination, urinalysis, and that must be included in the primary evaluation in any patient presenting with LUTs in order to identify the condition like the urinary tract infection, maybe that's a reason of that's LUTs, microhematuria, and diabetes mellitus. The next investigation is the prostate specific antigen, and we are measuring the prostate specific antigen. If the diagnosis of a prostate cancer will change the management, or when a patient diarrhea is abnormal, we are advising PSA, and we are measuring the PSA if it assists in the treatment or decision making. For example, if we are advising the combination therapy, so we need the prostate specific antigen level because it's affecting the PSA level. But the most important in all these things is the counseling of the patient. The patient should be counseled about PSA testing and the implication of a raised PSA test. This should be discussed with any patient who presenting with the alerts. Now coming into the renal function, I means the urea, creatinine, and electrolyte level. As we routinely advising these things, so renal function like urea, cret level, this is assessed only in a condition if your history and clinical examination telling you that the patient is needing the renal function, or ultrasound which you have performed that showing hydronephrosis, or when you are planning for any surgical treatment for mailers. So routinely we are not performing, but we are performing only if we need or we suspecting the renal impairment based on our history and clinical examination, like if the patient is diabetes, or ultrasound showing hydronephrosis, or the patient is having chronic urinary retention, or we are planning for any surgical treatment. So in that condition, urea and electrolyte should be advised in the primary assessment of the patient. Now coming into the post-wide residual volume, the measuring of the post-wide residual volume is very important. It should be included in the primary assessment of the mailers. And currently, there is no standard definition of the normal post-wide residual volume. But in our clinical practice, a post-wide residual volume of less than 30 ml is usually considered insignificant. But when a patient is having a post-wide residual volume that is persistently greater than 50, that could be regarded as important and should be evaluated. Now coming into the urinary flowmetry. The urinary flow rate assessment is widely used because it is a non-invasive urodynamic test, and we can take a very key parameter from urinary flowmetry, that is include the Qmax, the voided volume, the post-void residual flow rate. So this giving a lot of information, and the important things in regarding the uroplometry, that it should be only performed if a patient able to void more than 150 ml volume. So bladder volume must be more than 150 ml to assess or perform the uroplometry. Now coming into the imaging, and the assessment of the prostate size is important for the selection of the interventional treatment like open prostatectomy, enucleation technique. So now the question is that a transrectal ultrasound, which is better than the transabdominal ultrasound, is it should be performed in every patient? No, it should not be performed in every patient. It should only be indicated if the patient is having elevated PSA level, or you have performed the DRE and that is abnormal, are you planning for any surgical treatment? So in this condition, when the patient is having elevated PSA or abnormal DRE, or if the patient you are planning for surgical treatment, in these conditions go for transrectal ultrasound. Now coming into the cystoscopy or urethroscopy, is it should be performed in any patient? No, it should not be performed in every patient. It should be performed only in selected patient. Like if you asked in your history and you assessed that the patient is having a history of microscopic or gross hematuria, or the patient is having some history of urethral stricture or bladder cancer, or the patient who present with LUTS, in these patient urothroscopy should be performed for diagnostic evaluation. Are you performing the procedure in which you want to assess the prostatic middle lobe, like in a patient of urolapse? better to go and perform the cystoscopy before performing the urolift. Now coming into the urodynamic study, and is it important to perform urodynamic study in every patient? No, it should not be performed in any patient. There are some specific indication to perform pressure flow study in urodynamic, and it should be performed in those patients who presenting with unsuccessful previous invasive treatment. If a patient to present to you and he had a previous history of unsuccessful treatment for alerts, better to go for urodynamic study, and it should be performed in those patients. Urodynamic study should be performed in those patients who cannot avoid more than 150 ml of urine, and it should be performed in those patients who are having you are planning for a surgical treatment with bothersome symptom predominantly voiding bloods and the Qmax is more than 10, or in a patient having you are planning for invasive therapy having bothersome symptom voiding bloods. So in these patients having Qmax more than 10 ml per second, or the post-void residual volume is more than 300 ml, or the patient age is more than 80 year, or the patient age is less than 50 year. So in this condition urodynamic study is advisable. So there is some non-invasive urodynamic study which we call the non-invasive test, and that is involved the ultrasound measurement of the intravesical prostatic protrusion, and it involved the assessment of the distance between the tip of the prostate median lobe to the bladder neck and the mid sagittal plane, and we using it by suprapubically placing the ultrasound and measuring this distance, and it can be performed only when the bladder volume is between 150 to 250 ml, and it is being graded into three grades. The grade 1 protrusion include is between 0 and to 4.9, grade 2 include into 5 to 10, and grade 3 is more than 10 mm. Now, after a proper history examination and investigation, now we reach into the stage of treatment. So, there are three main treatment options for a patient of BPH. The first is the watchful waiting, the next is the pharmacological or medical treatment, and the last is the surgical treatment. We will discuss these one by starting from watchful waiting. And the pharmacological treatment may be include monotherapy or combination therapy. So if you are offering a patient the watchful waiting, there must be include a lifestyle advice and self care information to the patient. The patient should be reassured that the cancer is not the cause of his urinary symptoms, and there should be advised the periodic monitoring. Lifestyle advice include a relaxed and double winding technique, urethral milking to prevent post maturation dribbling. In case of constipation, treat the constipation, and the other things not to take a lot of coffee or drinking before sleeping. And whenever the patient to choose the watchful waiting as a proper treatment, then they should be follow up yearly to detect any progression in term of the occurrence of complication. Now coming into the medical treatment or pharmacological treatment of a patient of benign prostate hyperplesia, the it include monotherapy and combination therapy. The monotherapy include the alpha blocker, and the alpha blocker should be recommended to all men with uncomplicated LUTs and those with moderate to severe LUTs. The other is the combination therapy, which may include the combination of alpha blocker and 5 alpha reductase inhibitor. But the 5 alpha reductase inhibitor should be advised in a patient who present with moderate to severe LUTs and having enlarged prostate more than 40 ml. So 5 alpha reductase inhibitor should not be advised to a patient who having prostate size less than 40 ml. It should be advised to a patient with elevated PSA concentration, means more than 1.4 to 1.6. The indication for piafalba reductase inhibitor, that it should be advised to a patient with enlarged prostate more than 40 ml or elevated PSA concentration more than 1.4 to 1.6. But this 5-alpha reductase inhibitor, this is a very less effective when it is advised alone as a single agent. It is only effective and working better when it is combined with the alpha blocker. That's why it should be given in a combination therapy. And whenever you are advising the alpha blocker, the patient uh, become the symptom relieve within 1 week, and the pressure flow improve within 24 to 48 hours. But in case of pulporeductase inhibitor, the patient should be properly consulted regarding the very slow onset of action around 3 months. If a patient present to you within 2 weeks and he is saying that it's not working, so better to consult the patient before advising the pulporeductase inhibitor that it is having a very slow onset of action. And the patient should be also be consulted regarding the adverse effect of pulporeductase inhibitor, that include the libido, decrease in libido, erectile dysfunction, and less frequently ejaculatory disorder like retrograde ejaculation or ejaculation palaver are decreased in the semen volume. So the patient should be consulted regarding these things. And the piapalpa reductase, there are upper two types. One is the finasteride and the other is the dutasteride. And there are two type of receptor. One is the type 1 and the other is the type 2 receptor. The type 2 present in the intraprostatic tissue, while the type 1 present in the extraprostatic tissue like skin and liver. Regarding finasteride is a selective inhibitor of only type 2 receptor. I means the receptor which is present in the prostate, while the dutasteride, which is available on name of udot, it is a dual inhibitor, D for udot and D for dual. So it is a dual inhibitor and it inhibit both alpha 1 and alpha 2. And there are various studies that it decreasing the progression of the disease, and it decrease the rate of surgical procedure in a patient. In various trial we will discuss that in detail. So if I summarize it, the combination treatment with alpha blocker and 5-alpha reductase inhibitor should be advised to a man with moderate to severe LUTs, and there is increased risk of disease progression like the prostate volume is more than 40 ml or the PSA is more than 1.4 or 1.6 nanogram per ml. So in these patients, better to go for combination therapy. Now let's discuss the muscarinic receptor antagonist. The muscarinic receptor antagonist should be advised in a patient with moderate to severe LUTs and who having mainly storage symptom. But keep in mind one thing, they don't prescribe antimuscarinic in those patients whose post-wide residual value more than 150 ml, because with the prescription of this muscarinic receptor antagonist, the patient can present with acute urinary retention. Same we can also use beta agonist and the same principle, and just like muscarinic receptor antagonist, it should be given with same like the post-wide residual volume should not be more than 150. Antimuscarinic should be advised only if the patient having a storage symptom. And the next management is the phosphodiesterase inhibitor, and we are advising phosphodiesterase pipe inhibitor in a man who are having moderate to severe LUTs with or without erectile dysfunction. So to conclude, the pharmacological treatment is only for moderate to severe symptoms, and the conservative or watchful waiting is only for mild to moderate symptom. And the surgical treatment is, we have already discussed in detail their indication and when to advised in our previous lecture. But the various surgical treatment include resection, enucleation, vaporization, non-ablative technique and alternative ablative technique. We have given a proper lecture on this in our previous presentation. Now let's discuss some important trial. One is the Olmsted County study trial. This is a very good trial which basically telling us about the natural history of benign prostate hyperplasia. It is a longitudinal study, and it telling us about the changes during a year in a patient with LUTS. And it tell us that there is a chance of acute urinary retention 0.6% per year, the prostate enlarged 0.6 ml per year, and the mean Qmax decreased by 2% per year, and the IPSS score increased by 0.18. So it's a very good study to tell us about the natural history of benign prostate hyperplasia. The other two study, one is the MTOP study and the second is the combat study. MTOP study is actually performed on doxazocine plus penestride, and it tell us that the combination therapy is better than the single or monotherapy, and it telling us that it reduce the clinical progression. The other is the combat study, and the combat study is a combination of u dot. Combat mean combination of u dot plus temsolene. U dot mean due dot, due to steroid, and it's available in market on the name of due dot. And it the summarize that it reduced the risk of acute retention by 67%, and the combination therapy is superior as the more than monotherapy. So this is a whole detail about these benign prostate hyperplasia.